Comparative analysis of healthcare systems in Japan and the United States, accessibility, cost, and patient outcomes. Number 1334, Gerald C. EclaireMD Foundation. Category, Healthcare Systems. Abstract. This report presents a comparative analysis of the healthcare systems of Japan and the United States, focusing on accessibility, cost, and patient outcomes. Japan has achieved universal coverage since 1973, supported by strict government regulation of prices and efficient delivery of care. In contrast, the United States lacks universal insurance, incurs the highest per capita healthcare costs in the world, and produces relatively poor health outcomes despite enormous spending. A significant share of U.S. healthcare expenditure is directed toward certain industries, generating high profits while contributing to systemic inefficiency. This analysis highlights structural differences that explain these divergences, and concludes with reflections on how the U.S. might learn from Japan's more equitable and efficient system. Introduction. Healthcare systems across high-income nations differ widely in financing, organization, and outcomes. Japan and the United States provide a particularly revealing comparison. Japan is an archetype of universal access with government-controlled costs, while the United States represents a pluralistic, market-driven model characterized by high expenditure but uneven coverage. This study examines the two systems across three domains: accessibility, cost, and outcomes, using publicly available data and published sources, and provides a concluding reflection on policy implications. Methodology: the interaction of AI and NI in medical research. This article illustrates the productive interaction between artificial intelligence tools AI, i.e., computer, and the author's natural intelligence NI, i.e., human brain. AI demonstrates its strength through rapid access to vast databases, fast processing of large and complex datasets, and the ability to organize and refine text into clear, academically rigorous form. These attributes accelerate the author's medical research process, and bring consistency to extensive research projects. Yet AI alone is not sufficient. It remains a machine, limited in scope and imagination. NI, rooted in the human brain, contributes qualities that no machine can replicate: intuition, creativity, emotions, passions, and unique perspectives. The author, one of the first graduate students from MIT's AI classes in the early 1970s, devoted 32 years, approximately 80% of his entire industrial career prior to his post-retirement medical research, to AI technology development, and its many engineering applications. This long immersion in both theory and practice shaped his medical research style, which combines rigorous scientific and artificial intelligence background, with deeply intuitive and creative insight. When combined, AI amplifies the researcher's NI contributions, while NI provides direction, expands breadth, deepens inquiry, and interprets results from multiple angles. The outcome of his medical research becomes not only data-rich and precise, but also enriched by creativity, intuition, and philosophical depth. In this way, AI and NI together achieve a level of knowledge creation that neither could accomplish alone. Healthcare accessibility. Japan provides comprehensive and universal health insurance through two major schemes: employer-based coverage and community-based national health insurance. Since 1973, this dual system has ensured that every citizen, including the elderly, is guaranteed access to medical care. Patients enjoy freedom of provider choice, and outpatient services are widely available. Utilization rates are among the highest in the world, with the average Japanese citizen making approximately 13 to 14 physician visits annually, more than 4 times the U.S. average. Advanced diagnostic technologies, such as CT and MRI scanners, are also more readily available per capita, reducing delays in treatment. This may be one of the major reasons which, together with Japan's traditionally healthier diet and overall better lifestyle, has made it the leading country in health and longevity, at least among all advanced nations. The United States lacks universal health coverage. Insurance is fragmented across employer-based programs, Medicare, Medicaid, and private markets. Millions remain uninsured or underinsured, creating substantial access barriers, particularly for low-income and minority groups, while top-tier care is available for those with adequate coverage. Overall system accessibility is inconsistent, and often linked to socioeconomic status or geographic region. Healthcare cost. Japan maintains relatively low healthcare costs, spending about 10 to 11% of GDP on health services. The Ministry of Health, Labor and Welfare establishes a uniform, national fee schedule that sets reimbursement levels for all medical procedures, pharmaceuticals, and diagnostic tests. These fees are reviewed and adjusted every 2 years, and reductions are applied if service use spikes, discouraging overuse. Out-of-pocket payments are capped by income and age, with most citizens responsible for 30% of costs, seniors for as little as 10%, and absolute ceilings applied to prevent catastrophic expenditures. As a result, Financial strain from medical bills is rare. By contrast, the United States allocates 17 to 18% of GDP to healthcare, the highest among OECD nations. The Organization for Economic Cooperation and Development (OECD) is an international body of 38, mostly high-income, industrialized countries that collaborate to promote economic growth, policy, coordination, and social well-being. High prices for services, drugs, and administrative complexity drive this expenditure. Administrative overhead accounts for an estimated 25% of total U.S. spending, compared with 10 to 15% in countries such as Japan. Administrative overhead is far higher in the U.S. because its fragmented, multi-payer system requires complex billing, insurance, negotiations, and profit-driven administration, whereas Japan's standardized national system minimizes such costs. Out-of-pocket expenses remain unpredictable and burdensome, and medical debt is a leading cause of personal bankruptcy in the U.S. The lack of centralized price regulation perpetuates dramatic cost variation, with procedures such as MRI scans costing up to 15 times more in the U.S. than in Japan. This difference does not result from the technology or methodology of MRI scanning itself, but rather from human-related overhead charges. Patient outcomes. Japan consistently outperforms the United States on key population health indicators. Life expectancy at birth in Japan exceeds 85 years, among the highest globally, compared with approximately 78 years in the U.S. Infant mortality rates are lower, obesity prevalence is minimal at about 4 to 5%, and the overall chronic disease burden is correspondingly lighter. In contrast, adult obesity in the United States affects about 42% of the population, and when overweight and obesity are combined, nearly 74% of U.S. adults are above a healthy weight, compared with roughly 25% in Japan, where only about 4% are classified as obese. Clinical outcomes also favor Japan. For example, the 5-year survival rate for stomach cancer is about 60% in Japan, compared with 30% in the United States, while colorectal cancer survival reaches 68% in Japan, versus 64% in the U.S., and breast cancer survival is approximately 90% in Japan compared with 84% in the U.S. Kidney dialysis patients in Japan also demonstrate markedly lower annual mortality, at 13%, compared with 22.4% in the U.S., and 5-year survival, following heart transplantation in Japan, approaches 96%, far surpassing the global average of 72%. In addition, life expectancy at age 65 is significantly longer in Japan, with Japanese women living an additional 24 years and men 19 years, compared with roughly 20 years for women and 17 years for men in the United States. These outcomes reflect both healthcare system efficiency and the influence of preventive medicine practices, dietary choices, and lifestyle habits. The United States performs poorly despite extraordinary spending. Life expectancy has stagnated or even declined in recent years due to rising rates of obesity, diabetes, cardiovascular disease, and substance use. Health disparities are pronounced, with minority populations experiencing disproportionately worse outcomes. An estimated one-third of U.S. healthcare spending does not translate into measurable health improvement, reflecting deep inefficiencies in allocation and delivery. Overall, the U.S. system demonstrates a paradox of higher spending, lower results. From both medical and economic perspectives, U.S. performance is notably worse than that of Japan. Despite America's technological leadership in medicine, these outcomes highlight systemic weaknesses that stem from more fundamental issues, philosophy, priorities, behaviors, and the profit maximization tendencies of a capitalist framework that place financial gain above public health. Conclusive reflection. The divergence between Japan and the United States stems from structural design. Japan's healthcare system emphasizes universality, equity, and cost control through centralized fee schedules and regular adjustment. The culture of preventive care, healthy nutrition, and social cohesion reinforces systemic strengths. By contrast, the U.S. healthcare system reflects market fragmentation, decentralized pricing, and heavy reliance on private insurance, resulting in high costs, inequities, and waste. Accessibility is undermined by lack of universal coverage, and outcomes lag despite world-class biomedical technology and expertise in specialized centers. This comparative study underscores that the U.S. healthcare system's underperformance is not a consequence of medical capability, but of systemic inefficiency and inequity. Japan's experience demonstrates that universal coverage, centralized price regulation, and preventive health orientation can deliver superior outcomes at far lower cost. The U.S. may not directly replicate Japan's model, due to cultural, political, and institutional differences. However, key lessons are clear: improving access through universal insurance, reducing administrative complexity, and adopting cost regulation mechanisms are essential steps toward aligning expenditure with outcomes. Without structural reform, the U.S., will continue to allocate unprecedented resources to healthcare, while failing to provide its citizens with the longevity, equity, and security achieved by Japan. At the same time, Japan itself is not without challenges. Its nationwide government-sponsored healthcare system is facing potential insolvency due to the combined pressures of an aging population and a persistently low birth rate. While Japan demonstrates remarkable efficiency, accessibility, and outcomes, its financial sustainability remains a growing concern. In contrast, the United States struggles with inefficiency and inequity, but its younger demographic structure provides a different kind of opportunity if systemic reforms can align spending with results. Together, these cases show that no healthcare system is without challenges, and long-term success requires both effective design and sustainable demographics. Disclaimer: this content is for educational reference only and not medical advice. No doctor-patient relationship is created. You may share this report freely, but it must not be edited or republished as your own.